Well, I think we should say welcome to this symposium on an extremely important topic. It's a great honor to be a chair. My name is Ane Jacobsen. I'm a medical doctor and a PhD student from Copenhagen, Denmark. And it's a really great honor to present three speakers. I think a hallmark of this society and this conference is a really friendly and relaxed atmosphere. I was so pleased you said yes to participate. Louder? Okay. Or it's because I'm too Grand Danois. First we're going to hear John Newcomer talk about adverse effects of antipsychotic medicine to kind of outline the problem, which is a huge gap in life expectancy in people with severe mental illness. And then afterwards will be three different representatives of different non-pharmacological interventions. So we don't actually have anyone presenting pharmacological interventions against the increased cardiovascular disease risk. But I guess we will take that in the discussion in the end. So welcome, John Newcomer, professor at the Florida Atlantic University.
Okay, how's that? Can you hear? So I'm going to give a quick talk, and my assignment was to give some background and to sort of set up the problem. When we begin to treat patients with psychiatric disorders, we could focus on psychosis, but we can talk about other disorders as well. You begin to inherit an adverse event burden, and then we're challenged to come up with treatments to try to manage that burden. My disclosure slide. So this slide got a little mangled in the transition from Apple to PC, but all the first 8 or so arrows should be going up. The problem is that patients with major psychiatric disorders lose 25 to 30 years of life expectancy in the US public sector, and we think that's not so mysterious. This relates to high rates of well-known modifiable risk factors for cardiovascular disease. You can see them listed. The last three vertical lines actually should be arrows going down. And we think this also relates to poor access to high-quality care, poor adherence to therapies, and poverty never helped people live longer. The question mark is accurate. There's been some debate about whether the psychiatric disorders somehow intrinsically increase cardiovascular or cardiometabolic risk. And while I think there's actually a pretty compelling story for depression, there's been, I think, a greatly overplayed suggestion that patients with schizophrenia somehow intrinsically have premature cardiovascular disease. So the thesis behind a quick talk I'll give you is that a lot of this risk is actually coming from our pharmacologic treatments. We also think part of the problem is failures in known approaches, known primary and secondary prevention. Patients with psychiatric disorders are far less likely to be screened. They're less likely to be treated. So if you have a myocardial infarction, for example, and well studied in the US, you go into a general hospital setting with an acute coronary syndrome or myocardial infarction, you are much less likely to make it to the surgical suite and receive angioplasty or coronary artery bypass graft. You're also, in the year following that event, if you survive, you're far less likely to receive drug therapies, pharmacotherapies of proven benefit, and then more likely to die prematurely. So the thesis is a lot of psychotropic drugs. There's a particularly large body of literature now for antipsychotics, but there's a growing body of literature for various psychotropic drugs that they can increase these modifiable risk factors for cardiovascular disease and diabetes. I put up the American Diabetes Association slide describing the Cardiometabolic Risk Initiative. And the ADA started using this word in 2004, 2005 to talk about a constellation of modifiable and non-modifiable risk factors that increased risk for both cardiovascular disease, that is myocardial infarction, stroke, peripheral vascular disease, but also increased risk for diabetes, and hence the term cardiometabolic. And if you look around the perimeter of the slide, you see all of our favorite risk factors, and I'll call your attention in particular to the role of overweight and obesity, which has effects on risk both through changes in insulin sensitivity or increases in insulin resistance, but also direct effects through inflammatory markers and other pleiotropic effects. Okay, this is just a summary slide just to make a point about antipsychotic medications. At this stage, we do not have antipsychotic medications which are weight loss agents. All of them increase your risk for weight gain to one degree or another, but there's a high degree of variability. So drugs like olanzapine, for example, at 52 weeks have a well-characterized mean increase in weight of about 12 kilos, where drugs like aripiprazole and ziprasidone, for example, have well-characterized mean, some people more, some people less, but mean weight increases around 1 or 2 kilos. Okay, so I want to emphasize a little bit, just to give you background. This is data that is not looking at patients with psychiatric disorders. It's from the Framingham data set, looking at the number of excess cases of diabetes that you'll see per 100,000 population as a function of weight gain over 10 years. But what David Allison and colleagues did here was break the cohorts down into different groups at baseline who were either normal weight or under, maybe in the middle, a little bit of overweight, and overweight or obesity. And the point is that if you are already overweight or obese, and then you gain some degree of weight on top of that, this is where you see the biggest bang, the biggest effect size. So unfortunately, many patients, as you've seen in talks throughout this meeting, patients who, the baseline demographic characteristics for a psychiatric patient population, it often includes overweight and obesity. So this is where you can see changes in risk that map pretty well to large data sets that you can look at for patients with these disorders. Another bit of background, this is from the Nurses' Health Study, looking at just emphasizing the point that increases in body mass index in men and women, here spanning the normal and overweight range, we're not even into the obese territory, that increases in body mass index are associated with increases in relative risk for a number of different adverse health conditions that can increase morbidity and mortality. Notice in particular the steep curve for type 2 diabetes. In the same study, if we took this data out above into the obese category, what you would see is really an exponential increase, double-digit increases in relative risk. This is from an earlier study by our group, just looking at no matter what antipsychotic patients with schizophrenia were taking, or whether you were a healthy control, untreated healthy control or patient, really no effective group, no effective treatment group here. There's a really large, highly significant effect of body mass index on insulin sensitivity. And you can use surrogate measures of insulin sensitivity. This is an IV GTT measure, or you can use gold standard measures. It's always a very robust effect size. Now, I wanted to emphasize, and we'll talk a lot about antipsychotics, but here is a slide about antidepressants. I want to emphasize that many pharmacotherapies that are out there, not just in psychiatry, but also beta blockers, thiazide diuretics, have a well-characterized effect to increase your risk of diabetes. The relative risk ratios are usually about 1.5. So this is not a new problem in medicine. But it's a problem that it's important that patients, that clinicians treating patients with psychiatric disorders be aware of, that we're looking at a similar effect with antipsychotics and some antidepressants to increase your risk for a condition like diabetes. Now, in the general medical literature, looking at this risk-benefit question for beta blockers and thiazide diuretics, this has been very well worked out in very large sample sizes to try to understand, is it worth it to increase the risk of diabetes if I'm treating blood pressure with a beta blocker, or if I'm using a thiazide diuretic to lower blood pressure? And the answer turns out that it's net positive to treat. But I think we have to perform those same kinds of relative risk calculations and those same sorts of risk-benefit analyses in psychiatry. This is a study that we did a few years ago, very large sample sizes, looking at both an inception and a simple cohort for patients who were treated with different antipsychotics and the adjusted hazard ratio for incident diabetes. And the dotted line across the center here is that same general 1.5 relative risk ratio that you've seen before for antipsychotics, like on the last slide. And what you can see is that some of the newer so-called second-generation agents are in that same ballpark. But then some agents that we have in this analysis, clozapine and olanzapine, have a significantly higher risk than other antipsychotics. But the dotted line, again, all of them have some degree of risk. This slide makes the point, it was from a multi-state Medicaid data analysis. Medicaid is the public sector pharmacotherapy benefit in the US. And this was looking at children, pretty good sample size, who were either being treated with antipsychotic or treated with albuterol, something for asthma, as a control group. And what we saw was incident diabetes diagnoses emerging within 6 months of initiating treatment with antipsychotics. So again, rapid onset effects, measurable increase in risk. We have to now be considering this as part of the general risk-benefit ratio for treatment with these agents. This is a nice study that was reported a few years ago showing 3 different definitions of the metabolic syndrome. Metabolic syndrome is a constellation of cardiometabolic risk factors with particular thresholds or cutoff points for the 5 or so risk factors. The yellow bar is unmedicated patients with schizophrenia. First episode patients is that bar in the middle. And the final bar is more chronically treated patients with schizophrenia. And the point is that untreated and even early treatment patients are not showing much increase in risk. It's after chronic treatment. And again, suggesting, as I did at the beginning of the talk, that the risk that you see in this population is not so much intrinsic to the illness, but may be a function of chronic therapy. This slide got mangled, but what it's showing is the percentage of visits to doctors where an antipsychotic is prescribed, and the blue bar is seeing a psychiatrist, and the red bar is seeing a primary care doctor. And the point is, again, you have to be able to read all these things backwards, but there are multiple different diagnoses where antipsychotics in the US are being prescribed to children. And it's happening in both primary care and in psychiatric care, but this is an issue, right? And particularly pertains to some of the interventions that you're going to hear about later this afternoon. So I'll quickly give you the top-line results from a National Institute of Mental Health funded study that we did where we looked at antipsychotic naive children with disruptive behavior disorders. And it gave us an opportunity to have a treatment-naive sample, control for a lot of variables that were sort of confounded in other prior studies, and use really gold standard measures of outcome. 5-year study, 6 to 18 was the age range. We allowed multiple diagnoses in. Patients were randomized to risperidone, olanzapine, or aripiprazole. And we had about half the patients had a diagnosis of attention deficit disorder and were retained on stable ADHD treatments, stimulants in general. And this was to test a secondary hypothesis that people had hoped that stimulants would offset the weight gain, and I'll just jump to the punchline on that one. It doesn't work. Okay. We used infusion of non-radioactive stable isotopomers during hyperinsulinemic euglycemic clamps. I'll be happy to talk to people afterwards if you want to learn more about it, but it's a gold standard measure of insulin sensitivity that allows you to look at tissue-specific insulin effects at liver, at the adipocyte population, at the fat cells, and at skeletal muscle. We also use DEXA scans and MRs of the abdomen to measure body fat. This is the population. We end up with completers here. We end up with about 50 patients in each of the 3 randomized groups. You can see a range of ages. Notice the doses of the antipsychotics are very modest. These are children, again, clinician-driven doses, but these are low doses, so bear in mind when we look at the effects that there's the potential, based on prior literature, that these effects would have been larger if doses had been higher. Wide range of diagnoses. The predominant diagnosis was a kind of treatment-resistant ADHD. Patients had all tried some therapy or therapies prior. And very quickly, to get this out of the way, I mean, antipsychotics work behaviorally. The child psychiatrists, primary care doctors, pediatricians, they aren't insane, you know, when they're prescribing this. The reason they prescribe it is it's highly effective. And the modal kid in our study had been kicked out of school. They had been removed from the school system because they were sufficiently disruptive. Typically an assault had taken place. And so parents and their children are very eager to get them back into treatment. The problem is that you see significant increases in body fat during this brief 12-week period. And these are box plots. So the box spans the 25 to 75% confidence intervals. The bar is the median. The black line is the median. The whiskers are the 95% confidence intervals. So you can see substantial proportions, almost everyone on olanzapine, but very substantial proportions of the people on risperidone and aripiprazole are increasing body fat. This is a measure of insulin-stimulated glucose rate of appearance. This is essentially insulin sensitivity at your liver. And this is going down during treatment. It's not a huge effect, highly significant, but it's about a 4% decrease at liver. This is insulin sensitivity at the adipocyte. And again, about a 4% decrease in insulin sensitivity at the adipocyte. But here, also highly significant, about an 18% decrease in skeletal muscle. Your total body insulin sensitivity is predominantly skeletal muscle. It's 70, 80% skeletal muscle is driving. The insulin sensitivity at skeletal muscle drives the sort of whole body insulin sensitivity picture. So if you back away from these sensitive measures I gave you a peek at and just look at body mass index percentile, the public health measure of overweight and obesity in children, what you see is at baseline, the kids entering our study, highly representative sample, both demographically, from a socioeconomic standpoint, gender, ethnicity, but also they had the same rate of overweight and obesity that you see in the US general population, combined about 30%. But after 12 weeks, you have about 47% of that sample is now overweight or obese. So this was a quick data dump to try to give you a sense that even with a brief 12-week initiation of therapy, you already see very large and substantial changes in cardiometabolic risk. This led to a variety of groups coming out and saying, this is bad, we need to monitor this, we need to make interventions. This was the US effort from the American Diabetes Association, American Psychiatric, Clinical, AAC, American Association of Clinical Endocrinologists, and NASO, the North American Society for the Study of Obesity. But you saw the same efforts in Europe. You saw them in Australia. You saw them in South America. Everybody agreed that this was a problem. I'm not going to get into this literature, but we've published several papers showing that despite that tremendously consistent perception that we ought to be monitoring these patients and making interventions, there's a lot of data that indicates that before, during, and after all this promotion period for the new guidelines around monitoring, there was very little change in the rates of monitoring. So the challenge that you'll hear addressed in the talks that follow are not only do you have to recognize, you have to screen and recognize the problem, but then you have to make an intervention. So in conclusion, it's a high-risk population. The modifiable cardiometabolic risk factors are prevalent. Individual psychotropics, particularly well studied, are the antipsychotics, have different magnitudes of adverse effect. None of them are weight loss agents. I should qualify that by saying drugs like stimulants do produce, in isolation, do produce sometimes reductions in body weight. But when you add stimulants to antipsychotics, don't kid yourself that you're going to offset any of the adverse effects that you would otherwise see from the antipsychotics. Clinicians and the care systems can beneficially modify risk by making monitoring and interventions part of the process. Judicious use of medications is critical, but then in the talks that follow, you'll hear how can we, when we are required to use these agents, combine this somehow with another intervention to try to attenuate or eliminate some of the risk that we'd otherwise inherit. I'll stop there. Do you want to do one or two questions? Just one question, maybe? Okay, no, there's one.
Could you comment on the relationship between some of the metabolic effects and some of the cardiac effects, like increased QTC intervals and things? And it seems in a clinical situation you don't necessarily see them together. But,
yeah. So the question was commenting on cardiometabolic effects versus other, what we talk about as cardiovascular effects, like prolonged repolarization intervals, like the QTC is a measure on the ECG of repolarization. So I would just say that the QTC prolongation, despite a lot of efforts to go fishing for increases in mortality in our population, that's been very hard to find. Versus sort of well-established, quantifiable, easy to measure adverse effects on cardiovascular disease risk, CVD. Cardiovascular disease risk being the leading cause of death in the developed world, heart attack and stroke. This is what we're talking about today. So, all right, next talk.
Thank you so much for a tremendous talk. You're really presenting an uncomfortable truth. The next talker is Jackie Curtis from Australia, Sydney, University of New South Wales, presenting a solution for the problem.
Great. Well, thank you very much, Aina, for organising the symposium and for being here, everyone staying back so late at the end of the day. I'm very delighted to be here and speak about one of my favourite topics, and especially after you, John Newcomer, who I've actually always sort of one of the people who inspired me into this in the very first place back in those guideline days in 2004. So I'm here on behalf of my team, of the Keeping the Body in Mind team, as well as my IPhys collaborators, hopefully share some of our program that we've been developing over the last decade, and actually how you translate some interventions into routine practice. And luckily I don't have to do the entire introduction explaining the problem, because we've just heard a wonderful exposition on that. So this is the Bondi Centre. This is where all this work began. It's an old community mental health centre as part of a public mental health service. It's been involved in seeing young people with psychosis since 1995 with a first episode team, and more recently an ultra-high risk team in 2009, and very recently we have a Headspace centre at Bondi nearby. So here is the lovely new Headspace Centre. It's only been 5 months open, and just to share since we've got to talk about, as we heard from Joe Smith last night, talking to politicians is important. This is our Prime Minister opening the Headspace Centre just a few months ago, recognising the importance of youth mental health. So what I'm going to do today is really look at a bit of a 10-year lens on this topic as it relates to young people with psychosis, and then speak about our program itself and how this links then to the international landscape. And we've had a wonderful meeting just a few days ago here in Milan with the IFIS group, and then how this then translates into routine clinical practice, because I think many of you will want to know that. So let's start. We've heard that, and we keep hearing that there is a 25-year life expectancy gap, and I guess up till more recently we've thought this is someone's destiny, with someone's with experiencing and living with severe mental illness. But does this need to be the case? Certainly this is what we thought was the case when we started looking at this a decade ago. So I thought, given we're here looking back and moving forward, that we should really think back to, that I certainly think back to the 2006 IEPA meeting, which was in Birmingham, Beyond the Crossroads. At that stage our team took 2 posters there with this particular topic, first episode, physical health issues, metabolic syndrome. There was one other poster at that time from Swapna Verma's group in Singapore. Otherwise, there was no talks on this topic at all. And here we are, 10 years later, with not only 3 full symposiums on physical health issues in young people with psychosis, but also several talks, numerous posters. And of course, we had our really wonderfully well-attended IFIS meeting on Wednesday, where we have had international buy-in, collaboration and sharing, which was a really terrific meeting. I might talk about that a little bit more later. So in the last maybe 5 years, there's been a huge increase in the rate of publications about this issue. But this was a great commentary last year, which said, mental disorders and mortality, so many publications, so little change. So it's really along the lines of what John was saying in terms of the screening. Are we doing any better? I am going to try to put an optimistic thought out there I think things are changing, and here's why. This came out yesterday, and if you haven't read it, I really recommend it. It was from the New England Journal of Medicine, so full-on medical, non-psychiatric journal, where a cardiologist wrote about closing the mortality gap in people with mental illness and her perspective as a cardiologist of dealing with this issue. It's a terrific read. It's got lots of humane perspectives on how hard it is, but how important it is. It's part of a series of 3 papers on this in the New England Journal. So maybe it's getting the attention of the wider population. So evidence versus implementation. This is always a big question, and this actually is, thanks to Lisa Dixon, this concept and slide, which lags behind which. When we started this work a decade ago, there was very little evidence at all about this problem in young people with psychosis. There was evidence in people with severe mental illness, but not with young people with psychosis. So really, there was a sort of circle, and we just decided, we needed to do something about it, so we did. I think now there's the reverse issue where there's enough evidence and time to implement. In terms of cardiovascular risk factors, I don't need to go through those because we've just heard about it, but I just wanted to emphasise one thing, which was that when we started this work, we didn't know what the prevalence of metabolic syndrome in young people with psychosis was. So we did look at that. That was one of the first things we did after an initial audit. And it turned out that it sort of doubles by the time you come into our services and you've had about 9 months of care. So it was 13% in our first episode Bondi sample. And so that's compared to a drug-naive general population, 6%. And by the time you end up in our own clozapine services in our own hospital, by then you have a rate of 62% of metabolic syndrome. And then 54% is the general, a large Australian survey called the SHIP survey, looking at prevalence across not just clozapine clients, but people with enduring mental illness. And of course, the issue of tobacco. Now, we all know that tobacco is a huge issue, but in terms of first episode psychosis, 59% of young people at the time of presenting to our services are already smokers, and we have tended to neglect this issue as well. Another opportunity for cardiovascular risk reduction. I don't know if I know Mario's at the conference. I don't know if he's here, but we always use his slide over and over again. I can't put it up as often enough. This is just indicating how rapidly that weight gain goes on and very much reflects what you've just heard as well. But that means that the time to actually intervene and do something about this issue is right from the start, not later, waiting till the problem has accumulated. So what do we do? Keeping the Body in Mind program, that's what we've called it now. But back then when we started, we developed, this was in 2010, we developed a clinical algorithm and had a very strong motto, which is don't just screen, intervene. And really it's a two-sided sheet of paper that was designed for training of registrars in what to do with these problems as they arose. So in a clinical setting, it was done in collaboration with a med student at the time and an endocrinology colleague as well. So it was a how-to guide, very simple traffic light system, what to intervene, how to intervene and when to intervene, at what numbers of blood pressure to worry about, lipid levels, etc. So I'll go back to that in a moment. Meanwhile, what we did was actually try and transform the clinical service. So here was the front room in the Bondi Centre. It was a meeting room. There was client groups that happened there. We transformed that in with the team, and it's now a small gym, but it's very much the heart and centre of our Bondi service. And young people can come in every day. It's open and serviced by exercise physiologists, and it's very much a holistic care framework. I won't go into too many details. We've already presented this elsewhere in previous IEPA conferences as well. But essentially, what we did after having the algorithm, then doing an implementation and introducing lifestyle interventions, was to actually to evaluate it. So in 2013, we received some funding from New South Wales Health, and we proceeded to offer a 12-week structured lifestyle intervention with a clinical nurse consultant, an exercise physiologist, dietitian and a peer support worker. We then compared that with another service, another first episode service that had standard care, good care, but didn't have this structured intensive lifestyle intervention. And then we compared the results of that. This is what we were able to demonstrate in a small number, but nevertheless, young people who've come to our service and within the first 4 weeks of initiation of antipsychotic medications. What we demonstrated was that for young people in our service, waist circumference did not increase over the 12 weeks significantly at all, compared to the other standard care of an increase of 7.1 centimetres. Now, this is not bad care. This is what happens routinely. This is exactly what we're hearing from all these studies. Rapidly, within 12 weeks, that's what's usual. Same with the weight, an increase of 7.8 kilograms mean for the standard care compared to 1.8 non-significant increase for the Bondi team. So we thought that was pretty amazing. We were quite shocked about that, and we wondered whether that was just a one-off, and I'll show you that it wasn't. Looking at that another way, in terms of the percentage who put on clinically significant weight, only 13% of young people at the Bondi Centre actually put on clinically significant weight, compared to 75% of young people who were at the other centre. We have followed this cohort of young people up from the Bondi Centre 2 years later. So they had the 12-week initial intervention, and then they had treatment as usual. They could still come to the program, but there wasn't an intensive phase of that lifestyle intervention. And what we found was, again, quite remarkable that with that initial 12-week intervention, there was still no clinically significant weight gain at the 2-year mark or waist gain. So, I mean, that was quite surprising and heartening as well. That's something about actually intervening at that early stage was very important. I'll come back to the replication data of that in a moment too. Okay, on to the international landscape. So at IEPA, IEPA is a really great place to bring people together. I'm sure you've all had a great time networking, hearing really inspiring talks. But one of the things it did do for us is actually during IEPA Amsterdam 2010, I got to meet David Shires through the symposium that was then the first symposium ever on this topic in an IEPA meeting. And a group of us got together afterwards, had a cup of tea, later followed by other beverages. But at that stage, we had a really strong bonded about a commitment to a determination to do something about this problem, which we'd been struggling with from the UK perspective, thinking about it in Australia, and we formed IFIS. If anyone wants to look, there's free information on the website, there's Twitter sites, Facebook, etc., which has a lot of shared information, because that's been really critical. In terms of what then that group developed was the International Declaration, which we call HEAL. We've got copies of that for anyone who doesn't have it and would like it, and it's just a simple a few-sheeted document. Basically, it has an aspirational goal, which is young people experiencing psychosis should have the same life expectancy and expectations of life as their peers without psychosis. That's the aim of this. There was a series of targets that we developed, and this was with an international working group, which was really just the key experts in this area came together, came up with some guides of what we should be able to do. And interestingly, we made this up in 23. We made it up with carefully, but we were still aspirational. Here, this idea that 75% of young people should gain only less than 7% of their weight in the first 2 years, that was an aspirational goal, but we've been able to demonstrate that subsequent to the publication of this, that it is possible. We've had a real lot of buy-in and endorsement for this declaration internationally, and all this is available on the website, but I think it really speaks to how important a topic this is, that groups like diabetes groups, cancer groups, and colleges of physicians, surgeons, etc., as well as our psychiatric groups have actually endorsed this important document. And we've had 7 translations so far. In fact, there was a French one sent to us this morning as well, which we haven't put on because it's not, which is fantastic as well. So there's been a real interest, and this has been generated by people in their own countries. So that's all available as well on the website, and if anyone wants to do other translations, please let us know. There's Dutch one underway and Portuguese as well. Okay. The other thing that happened, and this is about collaboration and bringing together strong social movement values, is really how far this has gone. Our algorithm has been adapted into the UK Leicester algorithm by David and Helen Lester and colleagues. Canadians have got their version in Ontario. That's the 2014 Leicester update in the UK, which has now been adopted by the NICE guidelines. Japanese version, Italian version, Norwegian version, and now our adolescent version, and now an intellectual disability version as well. So you can see that a simple tool actually has generated a lot of interest in a practical sense. So these are clinical tools. We have not been formally evaluated, although there's a plan in Norway to do a formal evaluation. Okay, I'm just looking at the time because my timer hasn't gone on, so I have no idea how much time I've got left. It still says 0, so I can keep going. Okay, knowledge translation. So what's happened with the keeping our staff in mind initiative is something really also I'd like to share. With the data that we've been able to demonstrate in this small sample from a research-funded evaluation in 2013, and then with our interest internationally with the IFIS movement, our leaders actually took a very great blind leap of faith and showed extreme vision in my mind, and actually decided to fund permanent positions for lifestyle interventionalists. So here's our new team. We have 12 new lifestyle intervention clinicians that are across our local health district, not just our Bondi Centre, but across another couple of sites as well, for a catchment area of about 780,000 people. We have 4 nurses, 4 exercise physiologists, 4 dietitians, as well as peer support workers, all working across the age span. So we started off with young people, but it's now been extended to other age ranges for people to prevent lifestyle complications. So that's really heartening to see. So with this cultural shift, actually, the beginning of the work was how to set up a sort of Bondi-like service in places that hadn't had that before. So I guess the decision was made for a lifestyle intervention for staff. So we had all of the staff in the mental health service was surveyed, 700 of them, of which 200 responded to a survey about their own physical health. And then we've had initially 100 and now another group of 100 of those staff actually offered a 4-week lifestyle intervention, very similar to what clients are offered, but in a mini version, which has helped people look at their own physical health, but also think about the attitudes and well-being of the clients that they're looking after. And the aim is that that will improve patient outcomes in the long run as well. We have published a bit on that, and there'll be more coming soon, but not only was there an attitudinal shift from this intervention, but there was decreased weight in this as a sample as a whole, which we didn't expect. It was only a very brief intervention, 4 weeks, and then a follow-up at 16 weeks, and also decreased sedentary time in the staff. One slide on this replication, because tomorrow Philip Ward, my colleague, is going to be presenting a more detailed analysis of this. But what we then did with that group of new staff was just rolled out the Keeping the Body in Mind program across all the FEP UHR teams. And this is a look at the 73 young people who did receive that 12-week intervention. And again, we were able to maintain weight neutrality in that group, which again we've been really surprised about. That's not a research intervention, it's a quality evaluation, embedding these clinicians into routine care. Okay. So that's signposting tomorrow's session. I think I just wanted to share that there's a lot of other things that have rolled forward as a result of some of this initial work. And that is, and you'll hear some of that tomorrow if you are interested in coming. There's consumer resource that's been developed called Right From the Start. There's a Why Quit, which is our smoking cessation project that's I'm going to speak about tomorrow. There's a replication of our work in the UK with Jo Smith and her group. They're going to speak about that tomorrow in the SHAPE program. We've got carers studies. We've focused on sleep. We've got qualitative inquiry, which is looking at body mapping and artistic expression of how young people who went through the program have felt. And we've also got some examples of how these programs have been adapted in both Chile and in Italy. So if you want to come along to that, you're very welcome. So my view from Bondi is optimistic. I know that you're right, John, that the medications are immediately problematic in terms of their cardiometabolic sequelae. And yet they are essential medications, and they can be life-saving medications for young people who need it. I think we need to help with prescribing practices and stopping the over-prescribing of medications in non-indicated situations. And I think we need to, though, for those people who do need antipsychotic medications, we need to start at the beginning with lifestyle interventions because we know it can work. We need to also influence other non-first episode services in terms of what's possible. It's much harder later on. You're just going to hear a couple of talks which are going to highlight how difficult it is if you wait till after that beginning period. And thank you very much, looking back and forward.
Thank you so much for a really inspiring and uplifting talk. Are there any questions? I think we have time for one or two questions.
I couldn't tell the time. Yes. Yes. Yes, well, yes. Well, I didn't go into detail with the algorithm, but definitely the algorithm has got metformin on it, and we've got guidance by our endocrinologists about that. We definitely do recommend considering metformin in the situation where lifestyle intervention hasn't been successful. So if you do the 12-week intervention in particular, and if that's not successful and you see the numbers, either weight or lipids or glucose going the wrong direction, then we do actually recommend considering metformin in a careful way. We've got prescribing recommendations on how to do that in young people. Great, thank you.
That really was a wonderful talk. And I'm happy we started out with a positive story. Becomes a bit more gloomy now. Maybe we should dim the lights. My name is Ane Jacobsen, as I said. Could we start the time? And yeah, there it is. I have no conflicts of interest to declare. Well, Jan Newcomer and also you, Jackie, you built up the background pretty well, so we can just go over shortly what we already know. We know that the life expectancy is reduced up to 30 years in people with severe mental illness. We know that cardiovascular disease is the most common cause of death. And we know that the prevalence of cardiovascular disease is up to 3 times increased compared to the general population. We heard about adverse effects of medicine. There might also be some genetic factors and then lifestyle factors, and that's my focus area. Besides being obese, people with severe mental illness are also more likely to smoke. They are more likely to have diabetes, hypertension, dyslipidemia, and metabolic syndrome. The literature is quite rich on the area. I really like this meta-review by De Hurt. I think you also contributed to a newcomer to it. And as we already heard a lot about, there's also these disparities in healthcare, meaning that people with severe mental illness are less likely to have their metabolic factors measured and treated, as hypertension and dyslipidemia. So the metabolic syndrome is quite often underdiagnosed and undertreated in the population. If we go into what has already been tried out in behavioral interventions, reducing cardiovascular risk factors, these are 4 really great trials investigating behavioral interventions against cardiovascular risk factors. Really great high-quality studies with large populations. And as we see, they have quite promising results in a great proportion of the participants. That's the first one. Losing a clinically significant amount of weight. As you see, I don't know if the slide is clear, these are the controlled populations, and they also tend to lose quite a lot of weight as well. Then there's the thing that all studies end after 12 or 18 months, and only one of the studies, the one by Bartels, has a follow-up period preceding the time of the intervention. So it leaves us without evidence that these interventions actually work in the long run. We really lack some evidence of long-term effects. And that leads me to my research questions. Is it possible to create a sustainable lifestyle changes in people with severe mental illness? And is it possible to not just work on obesity, but also work on other risk factors like smoking and hypertension, physical activity? Would it be feasible? Would it possibly be enough with the care coordination, or will lifestyle counseling add to the effect? And so we created the Project Change 3 years ago. We made the inclusion criteria really broad in order to create a great external validity. So we included all patients above 18 years old diagnosed with either schizophrenia, schizoaffective disorder, or persistent delusional disorder, who had a waist circumference above what is recommended by the Danish health authorities. We excluded only people who were pregnant or who couldn't give informed consent. So we didn't exclude homeless people or people with suicidal ideation or the most ill. And also we didn't exclude people with substance abuse. The intervention was a tailor-made intervention. Each patient got affiliated with a change coach who was a special educated occupational therapist or physiotherapist or dietitian with psychiatric experience, who got a special education in motivational interviewing and smoking cessation support and healthy lifestyle choices and healthy dieting. It was based on this model, Stages of Change, you probably all know, saying that whenever you're about to make a lifestyle change, you will be somewhere in this circle of change, whether it's about quitting smoking or eating more healthy or being more physically active. You can either be in the pre-contemplation phase where you're not ready to change at all, and then you can move through the phases through considering change until actually changing and then maintaining, and of course accepting that people will have fallbacks now and then. Each coach got the baseline result from our inclusion period and then met up with the patient, and during the first consultation they tried to agree on what was most possible and what was achievable and what was most important to work on any of these areas: smoking, dietary advice, and physical activity. And yeah, as it was individually tailored, there were no mandatory elements, but we aimed for the coach to meet with the patient at least once a week, and some people more. Besides that, they used SMS contact, telephone contact, home visits. There was a center where the patient went, and they arranged cooking groups, and they could go grocery shopping or even go out for a run or a walk if the patient was ready for that. So it was really flexible and outreaching. Then the last arm of the study was this care coordinator role, that was meaning to ensure affiliation with the general practitioner and ensure that the patient got their whatever health problems they might have, that they got them monitored and treated. Special focus on obstructive pulmonary disease and hypertension and diabetes. Our outcome was something called the pre-card. It's building on the Copenhagen risk score, which is a validated algorithm, validated by a large public survey in Copenhagen. It is a composite risk estimate, estimating your risk of having a cardiovascular event during the next 10 years. But we standardized the age to age 60 years because, after all, a lot of our patients were pretty young and they would have an unmeasurably low risk if we just used their real age. It consisted of some modifiable factors: BMI, cholesterol, high density lipoprotein, smoking status, and your systolic blood pressure, and then some non-modifiable factors, whether the patient had diabetes, whether they had already had some cardiovascular event, and whether one of their parents had had a cardiovascular event in an early age. So that was our primary outcome. Besides that, we had a huge test battery. We tested fitness with a bicycle test. Here we see our lovely assistant Mette with one of the first patients. We took waist circumference and HbA1c as a measure of diabetes, and lung function in forced expiratory volume in 1 second. Besides that, we asked about dietary habits with the food frequency questionnaire, asking about a lot of items. How often do you eat fish? How often do you eat vegetables? How often do you drink sugary beverages, and so on. Apart from that, we asked, what did you eat during the last 24 hours? That's quite a hard question to answer. But it was really interesting to hear what people ate. We asked to physical activity with the physical activity scale, how much sedentary time and how much moderate and vigorous physical activity people had. We asked about substance and alcohol abuse, and we tested cognition with the BACS test, positive and negative symptoms, and quality of life using the MANSA scale, which is a 16-item scale, asking how satisfied people are with different elements of their life, and in general, how satisfied are you with your working situation and your social network and your family situation, your sex life, on a scale from 1 to 7, where it goes from it couldn't be worse until it couldn't be better. And we asked how patients perceived their health and asked them to to tell on a scale from 1 to 5. This is the flow chart of the study. Last time there was a IEPA conference in Tokyo. My colleague Helene Speyer, who did the inclusion, presented the baseline results. That was back then. We assessed 513 patients for eligibility in Copenhagen, the capital of Denmark, and Aarhus, the next biggest city. And we randomized 428 patients to one of the 3 treatment arms. I forgot to say the second treatment arm was a care coordinator alone, and that was a psychiatric nurse who only undertook this role of care coordinating. So making sure that health problems were followed up on. The intervention went on for 1 year, and after 1 year we did follow up, and the results just got published this spring in World Psychiatry. So I'm just going to go through them shortly, and we just recently finished the 2 years follow-up in June, and now I'm working on the analyzing. So today I have some preliminary 2-year results and the 1-year results. The baseline characteristics. I'm pretty proud of, I think we really managed to include a really sick population. Of course, we selected them for being abdominally obese. Apart from that, half of the patients were smokers, 15% had diabetes compared to 4 to 5% in the background population, at least in Denmark. Less than 1/5 of the patients were physically active, at least 30 minutes a day, which is what is recommended by the Danish health authorities. And almost half of the patients were not physically active at all, meaning they were sitting and laying all day. Of course, that was also including work, but I think 62% of the patients were on early retirement, so not so many patients actually were on the working market. The duration of illness was 17 years in mean. That means I'm kind of a black horse on this conference. Can't really call it early intervention. But I guess it's good to show how it looks when we don't intervene early. The GAF, Global Assessment of Functioning score, was 43. That's a scale that goes from 0 to 100. So they were pretty dysfunctional, you can say. After 1 year, the results look like that. Somehow this figure has sunken one bit. This looks pretty good, but it was supposed to be 1 point higher. I don't know what happened to the Excel figure. But at baseline, the mean pre-card value in the coach group and the control group and care coordination group was almost 8%, meaning if the patients had been 60 years old today, their risk of having some cardiovascular event during the next 10 years was almost 8%. And there was no significant, statistically significant difference. After 1 year, the change group had gone up to 8.5%. The care coordination group had gone up to 8.4%, and the control group had a pre-card risk of 8.0. So there was a tendency that the control group actually did better, but it was, as you see, not statistically significant at all. And I could show you the rest of the 1 year results, but all the secondary and exploratory outcome looked pretty much the same, flat lines, no statistically significant changes in any outcome whatsoever. After 2 years, I wish it was just like this. 24.78% of the coach group had lost at least 5% of their baseline weight, but 31% almost had gained a clinically significant amount of weight. And it looks pretty much the same in the 3 groups. There's a tendency that the control group does a little bit better, but it's not statistically significant. The secondary results, the average weight was just above 100 in all 3 groups. The BMI was around 35. They bicycle fitness test around 19 mean, and just to compare, a healthy adult should be at least 45 in a fitness test, or at least a 30-year-old woman. So having a fitness test of 19, that's below, really low, even for a 70-year-old person. So it's extremely bad. The waist circumference was around 115 in average, and no statistically significant differences between any of the groups. The blood pressure was actually in the normal area, around 130 systolic blood pressure. Cholesterol was around 5, and no change at all. 5 is just in the upper limit of normal cholesterol. Approximately half of the patients still smoked, and their HbA1c is also in the higher level of in the normal level. Or yeah, and more flat lines. They moved moderate or vigorous. That means walking or running or doing anything less than 3 hours in average, and spent in average around 10 hours sedentary. Funny, it looks like the quality of life goes up a little bit. It's also not statistically significant. And it was quite amazing talking to people about quality of life. There was a patient who, at my age, who had just been hospitalized for 4 months, and he was constantly hallucinated on hearing and on a really heavy dose of clozapine. And he told me he slept for 16 hours a day, and the rest of the day he lived at home with his mom, who cooked for him, and he read a little bit in the Quran, and apart from that he just tried to cope with the voices. And I just remember he answered 5 out of 7 to all the questions in the Mensa. He was pretty satisfied with life in general, and even with his social life. He laughed when I asked about friendships and sex, and said, people like us, we don't have sex life and we don't have friends. But he had kind of come to terms with it. And in general, you see, they don't score so bad on the Mensa. And they don't feel so ill either. There's no correlation between how you perceive your health and how ill you are. So to conclude, we can at least conclude that there was no effect whatsoever on any of our outcomes of our lifestyle intervention. A few things have to be said. The healthcare system in Denmark is really good. We have free healthcare for everybody, so the results might not be applicable to other settings where the healthcare system isn't so rich and good. And then a few of what we consider the forces of the study may have affected the results. We had these really broad inclusion criteria, and of course if we had focused on people who were motivated, we might have gained some more positive results. Yeah, that really underlines the importance of early intervention. So implications for further results, ideas could be multimodality, I really liked your algorithm, Jackie. I think it's too bad it hasn't been translated to Danish yet. And that also comes under structural changes, like on the political level. You might argue that maybe our behavioral and really motivational-based intervention simply didn't do that. What we need are structural changes, like smoking prohibition in institutions, or delivering free healthy meals, or free fitness club memberships, and then algorithms, securance of screening and intervening. I really like that slogan. Further research could also go into multimodality in peer support and in internet, smartphone-based, or even virtual reality results. You can say there's plenty of way to go, or room for research and room for improvement. But I think we shouldn't take on a nihilistic view on this. Thank you so much for your attention, and thank you to the participants. Any questions? I think it's on already. No, it's not.
The comment you made about the patient who, the comment you made about the patient who really seemed to be satisfied with his life despite what we would see as a very low quality of life and unsatisfying. I wonder whether that underlines some of the issues with engaging with groups with very established mental illness, in terms of there really is very limited motivation to change. I'm wondering whether you looked at motivation to change in your groups.
Thank you, that's a good comment. No, I could have wished that we had actually, there is a measure for where you are on this stages of change, and we didn't do that.
Thank you. My name is Rhonda Wilson, and I'm moving to Denmark shortly as an e-mental health researcher. And I'm really interested in your presentation, and particularly interested, and found it rather ironic, I guess, that you had a bike test. So I thought that was rather amusing in the sense that you ride lots of bikes in Denmark. So congratulations on incorporating culture into your research. But I was really interested that you had similar results across all of those areas. And what I was wondering was whether you looked at personalities in terms of your coach and your care coordinator. And could personality of the clinician delivering the service have had some impact, some of those qualitative measures, might they have been an influence in the uptake and influencing any change potential, do you think?
Thank you so much. Yeah, that's really a good question, and I've done the same thoughts. I have a colleague also called Ane who's doing the qualitative part of the study, and she has done huge qualitative interviews with the patients. And yeah, we haven't described the personalities of the coaches, but I've thought myself that from meeting them that I wouldn't necessarily let them into my life and let them coach me. So it definitely has a lot to say. But maybe you have suggestions for how to measure it.
Hello, yes, thanks for that talk. It's very interesting. Peter Galler from St. John of God Hospital, Lateral Ministries. We have a group lifestyle intervention that we're running, and like yourself, now we haven't done our results really yet, but preliminary. we're not seeing a massive decrease in BMI. However, we also did a qualitative interviews with the clients, and they are reporting that they are really enthusiastic about the lifestyle intervention. And what we have noticed is that they are increasing their exercise. We gave them pedometers, and they're really focused in on. They love the pedometers, and they're focused in on their 10,000 steps, and that seems to be a reward in itself.
Was that a part of your intervention or a part of the?
Yes, it's part of the what we did. But I'd also like to suggest to you, and something that I mentioned to David there, is that even though your results are flatline, at least not increasing. The BMI is not increasing. So just your comments on that, perhaps. Thank you.
Yeah, they aren't increasing that much, but they aren't in the control group either. So you might argue, or I definitely think there's a spillover effect, you can call it, from just joining the project change. That was my impression. I was a blinded assessor, of course, but I got the impression that all patients joining, whether they had the intervention or not, they got motivated just by talking about their health, and they came for this baseline result measure, and of course we gave them the results whether they were in the intervention group or not. I remember calling a patient to make an appointment for an interview, and she said, could we just wait a few days? I just need to go down a few kilos, because she wanted to make a great impression on us. And so we didn't have do you call it pedometers? Walking, yeah. If we had given that to all groups, I guess that would have had an effect as well. There's definitely a spillover effect. Yeah, I think we are out of time. Yeah, sorry. Let me present Faith Dickerson, great honor, a professor in psychology at the Shepherd Pratt healthcare system, and also working with Johns Hopkins University. Welcome.
I'm really pleased to be here to tell you about the cardiovascular risk reduction trial that I'm involved with. We don't have results yet, so we remain very, very optimistic. It's very similar to the CHANGE trial, but you may be interested to see in what ways it's different as well as in what ways it's similar. I'm here on behalf of Gail Daumet and the IDEAL study team out of Johns Hopkins University in Baltimore, Maryland. Note the other individuals who are leaders in this trial on the slide. I don't need to review the background slide. It's been said now several times. Certainly we know that people with serious mental illness have biological risk factors for cardiovascular risk disease, and also social factors. It's been alluded to: unemployment, low income, and sometimes difficulty accessing medical care. We also know that as a group, individuals with serious mental illness have cognitive impairment and psychiatric symptoms that impede day-to-day functioning and moreover make health behavior change really challenging. So any intervention to reduce cardiovascular risks in this population needs to take these factors into account. Now, why did we call the study IDEAL? We did because the American Heart Association has set national goals for reaching ideal levels of cardiovascular risk factors in order to reduce deaths from cardiovascular disease. And we wanted to help our patients to achieve these same ideal goals. This slide shows an overview of the trial design. I'll be going into each of these elements in some more detail. Basically, like the CHANGE trial you heard about, this is a randomized controlled trial. We only have 2 arms. The setting is a community psychiatric agency. We aim to enroll 250 participants with serious mental illness. We're still in the enrollment phase. We're not quite at 250 persons yet. Each of them does have at least one cardiovascular disease risk factor. The intervention is an 18-month intervention, and this is just a little bit longer than the CHANGE trial, but in the same ballpark. Our intervention also involves a coach. We call ours a heart health coach, and this is an individual who provides individual counseling to the participants. We also have a heart health nurse who plays a role in interacting with the primary care physicians and psychiatrists around medication and other issues. Our comparison condition is some environmental changes at the psychiatric agency, including access to healthy foods and also exercise classes. Our primary outcome is very similar to the CHANGE trial. We are looking at change in the Framingham cardiovascular risk score. Our intervention was informed by social cognitive theory and behavioral self-management. The circles on the left-hand side of the slide represent some of the different providers who may be interacting with the patient, working towards the goal of reducing cardiovascular disease risks with the aim of improving cardiovascular health, improving quality of life, and ultimately reducing premature mortality. The setting was one large psychiatric agency in central Maryland. Maryland's the state within the United States where we're located. This agency has 4 sites. Each site has a day program. This is a place where patients with serious mental illness can come during the day, and most of our participants attend the day program 2 or more times per week. So this setting is really ideal for a project of this kind because it allows for individual, group, and environmental interventions. Like in the CHANGE trial, our inclusion criteria are very broad. People have to have serious mental illness, defined as schizophrenia spectrum, bipolar disorder, recurrent depression, and have to have at least one cardiovascular disease risk. This is overweight or obesity, or a current smoker, or high blood pressure, or diabetes, and or high cholesterol. The exclusion criteria are also minimal. They cannot have had a recent, as in the last 30 days, cardiovascular disease event, or any serious medical condition that precludes their actually participating. And unlike the CHANGE trial, we do not allow people who have an active substance use disorder within the last 30 days. Here are the characteristics of the baseline sample to date. As I said, we're still enrolling, so this is about 90% of what the final sample will be. I show here the data for the total sample to date, as well as for the young adults on the far right of the slide, persons aged 18 to 30. Now, these are not necessarily people who have had a recent onset of psychosis, but certainly they're closer to the onset of illness than is the sample overall. The racial distribution is consistent with that in our geographic region, and the sample is about equally divided by gender. What's of note, and perhaps not surprising, is the high body mass index on average above 30, and this is true in our young adult group as well as in the sample overall. And I should add that the mean age in the total sample is 48, and that's about 10 years older than in the CHANGE trial. So you might say we have an even bigger challenge. The high waist circumference is also of note, again found in the young adults as well as in the sample overall. What about the individual cardiovascular disease risk factors? Not surprisingly, a high percentage of the sample are cigarette smokers, including the young adults, and a very high percentage in both groups have a BMI that's in the overweight or obese range. In terms of the total number of risk factors for the sample as a whole, as well as for the young adults, what's really striking for me here is that 18% of the sample, that's almost 1 in 5, have all 5 risk factors. and 11% of the young adults. So what is our active intervention? It is a very structured and intensive intervention that is delivered largely by the coach. The coach is at the level of a psychiatric rehabilitation counselor, but I have to say that this person is very specially trained and is highly supervised during the trial. There are actually several coaches working on this study. The coach provides individual counseling to participants as often as weekly throughout the 18 months of the study period. The coach collaborates with other staff at the agency and other support persons in the person's life. Then there's the heart health nurse. This person is also a key personnel. The nurse provides individual counseling around diabetes for those people who have diabetes and around medications and medication management in general. The nurse plays a really active role in coordinating with primary care providers around these target cardiovascular issues, and actually accompanies patients oftentimes to their medical visits to make sure that the issues are being addressed. The nurse also actively collaborates with a psychiatrist, particularly around smoking cessation medication. We feel very strongly that for patients who are smokers and who are willing to quit, they really benefit from smoking cessation medication, and the psychiatrist is typically the one to prescribe this. Here are the targets of the intervention and some of the strategies that we use. In terms of overweight or obesity, we had a previous trial that was shown on the slide before, the ACHIEVE trial. And in this trial of weight reduction, we did find a success, and we've used some of the same strategies in IDEAL that we used in ACHIEVE. We provide individual counseling focused on small portions, focused on not drinking sugar sodas, and eating more fruits and vegetables. This is a sample of some of the very clear, simple, and direct messages that are part of the intervention. In terms of physical activity, we've arranged for the different sites of the psychiatric agency, each site to provide exercise classes 3 days a week with staff from the agency. Then there's smoking. We use a motivational interviewing approach, as you've heard about before. We really promote smoking cessation medication and use contingency management based on expired carbon monoxide from a breathalyzer with a level of less than 8 parts per million, yielding a reward because that's consistent with not smoking in the last day or so. But I want to say something more about our smoking cessation piece because this is so central to our intervention. Because smoking is so prevalent in this population, and because if you are a smoker, the very best way to reduce your cardiovascular disease risk is to quit smoking. This is because it's the best way to improve your health and to extend your life. So for our participants, we assessed their motivation to change at baseline and used a stage-based approach to our smoking intervention. For those participants who smoke and are willing to quit within 30 days, we are delighted, and we make that our highest priority. And for these individuals, we have a 13-session counseling protocol, which is focused on preparing the person to quit, helping them quit, supporting them through that, and helping them to maintain abstinence, hopefully also with the help of pharmacotherapy, which is started several weeks before the quit date. For those participants who smoke, who are maybe interested in quitting, but not right now, please, we offer another set of counseling sessions, 4 sessions of motivational enhancement. We hope that they will proceed to active quitting into that phase of the intervention, but if not, we repeat these sessions every month or so. For those who are not interested in quitting at all, we proceed to focus on other cardiovascular-rich targets, of which there typically are, but we don't give up on the smoking. We have a motivational counseling session that we repeat periodically throughout the full 18 months of the trial. I should add that at baseline, our participants are about equally divided among these three groups. Okay, so what are the strategies used by the heart health interventionists? Motivational interviewing, which you've heard about before. The approach is very individualized with goals set collaboratively between the participant and the coach. The day program environment allows for frequent contact between the interventionists and the participants, which we think is helpful, and the involvement of other agency staff. The nurse communicating directly with medical providers and interacting directly in person with the medical providers with the patient is a crucial strategy. And we also have an incentive point system, not only for a low breathalyzer score for smokers, but for meeting attendance. Our primary outcome, as I noted, is change in the Framingham risk score. We're also going to look at change in these individual risk factors. We're also going to look at other outcomes, including health status, quality of life, psychiatric symptoms, and medication adherence. We've had a number of challenges. The biggest challenges involve smoking. The psychiatric agency is a reasonably quite permissive environment when it comes to smoking. They smoke ad lib outdoors with very few restrictions. We've also had some pushback from the staff who sometimes voice some of the well-known myths about smoking and mental illness. Oh, they can't quit. Oh, you're going to upset them if you ask them to quit, and other such concerns. So we have to work very hard with these providers to educate them about the truth about smoking and mental illness. We've also encountered some inertia on the part of primary care providers. Occasionally, they're a complacency really about the medical issues and cardiovascular risk factors that our patients present. We've also been concerned about staffing those exercise groups because we want to make sure they keep going. And in general, at times, we've had a challenge of balancing the needs of our study with all the other clinical demands and clinical issues going on at the agency. Finally, we've had a challenge in maintaining patients in a long-term intervention. We worked very hard to reduce attrition, both in the active group and also in both groups for the purposes of data collection. So what do we think has been facilitated? Well, we're not sure because the trial isn't over yet. And we hope to have recruitment completed in the next 2 months, and then the study itself will be completed about 2 years from now. We don't know what's effective. We think our close follow-up of patients. We think the rapport between the coach and the participants and the coach and the agency staff. We think our coordination, our direct coordination with primary care is really important, and that the role of the nurse is particularly crucial. And we also are putting a lot of stock on our specialized approach to smoking cessation, and do observe so far that it has enabled quite a number of our participants to quit. And finally, we think that our incentive program may also be of benefit. That's the end of my talk, and I'm glad to take any questions.
Can I just ask a question about the rates of diabetes? I was really struck at the high rates of diabetes in both age groups, but particularly the older age group. I mean, that's 35% is 4 or 5 times higher than I'd have expected for general population.
No, our patients are on olanzapine, they're on clozapine, they're on medications that we've heard are really risk factors for diabetes.
It's extraordinary.
Yeah, it is extraordinary.
And were they known to have diabetes, or did you discover it in your assessment?
In most cases they were known to, but in some cases we did discover it because they get a very thorough workup initially. Yeah. So we do uncover some issues, and then we struggle to decide how we classify them initially, sure. based on our own findings that may occur after enrollment. Yeah. Yes.
Faith, could you just tell us, I presume in both the active and control groups, you've got standardized pharmacotherapy for the risk factors when there are published guidelines, treatment of diabetes, treatment of cholesterol, blood pressure, et cetera. Can you say something about standardization?
Well, the standard of care is variable, Our patients are not seen at any one center. They're seen by a multitude of primary care providers as well as psychiatrists, not all at this agency. So we can't assume that they're currently receiving adequate treatment, which is why our nurse has been so crucial in trying to advocate for those changes. But in the control condition, we don't make any intervention.
So the control condition, so do you expect that you may see differences in adherence to recommendations around pharmacotherapy?
We assume so, yeah.
Hi, Alan Rosen from Sydney. There's a little pattern going on here, and it's being threaded through the different presentations. And there are opportunities here for providing an intervention not just on service users, but interventions on staff. And I guess this has been mentioned by Jackie in terms of the weight and the weight and the activity, diet and activity programs for staff, however concertinaed, but still getting them also to then get that mindset so they can actually deliver it more effectively and role model more effectively for the clientele. I would think the same opportunity would be available with a smoking cessation with staff who are very cynical, because they probably are smokers, I would think.
They are smokers, probably a little bit more than the general population, but not nearly as much as the patients, and that's a really, really good issue.
Okay.
The agency itself, apart from the study, did have an initiative to reduce staff smoking. So there was some effort there, but I'm not sure how effective it was.
I'm taken by Miles Rinaldi's work on motivational interviewing for staff to get them to be interested in vocational rehabilitation, and that seemed to be effective. And I'm just wondering if we should, because that's the other thing that's being threaded through, is motivational interviewing, and I think there are similar opportunities in Anne's study as well. And I'm just wondering if we don't do enough in terms of intervention on ourselves, and that we don't operationalise the principles we espouse on ourselves.
I think that's a really good point, yeah.
Thank you, that's a great comment. And thank you so much for an extremely interesting talk. I'm really curious about following your results. I think we're out of time, actually, so we will just say thank you and good night, and thank you for being patient.